Ever had that feeling? Just inexplicably sluggish, maybe a bit pale, low energy, and you can't figure out why.
Yeah, happens to everyone sometimes.
And you might think, oh, maybe I need more iron. But what if, and this is kind of wild, what if your body was deliberately making you feel that way?
Uh-huh.
Not because something's broken, but because it's trying to protect you. Now think about that with animals, like a horse. What if their bodies are doing the exact same thing for a really profound protective reason?
It's a fascinating idea, isn't it?
Welcome to the deep dive.
Mm.
Today, we're jumping right into something that sounds maybe a bit clinical, but it's actually, well, pretty amazing. Anemia of chronic disease, or ACD.
Right.
And what we want to unpack for you is how this is a brilliant example of the body's own defense systems working in surprising ways.
That's spot on. And for this deep dive, we're drawing from some really solid expert sources. We've got detailed veterinary guides on ACD, looking especially at horses, plus, the foundational vet hematology texts.
Yeah, good stuff.
They really lay out how the body handles these internal battles.
So our mission today for you listening is to really get what ACD is, how it works, right down to the cellular level, why it's almost always a signpost for something bigger going on, and what makes it so different, especially when you talk about treating it. Get ready for some moments where you just go, okay, that's why. It might change how you think about anemia entirely.
Definitely. So let's start right there. What is anemia of chronic disease? The sources also call it anemia of inflammatory disease, or simply anemia of inflammation. And get this, it's actually the most common type of anemia we see in horses.
Really? Most common. Okay. So what are its defining features? How does it look on paper, so to speak?
Well, typically it's a mild to moderate anemia, and crucially, it's non-regenerative.
Non-regenerative, meaning
Yeah.
the body isn't really trying to pump out lots of new red blood cells to fix it.
Exactly. The factory isn't ramping up production like you might expect. And the red blood cells themselves, usually they look normal. Normal color, that's normochromic and normal size, normocytic.
Okay, so nothing obviously wrong with the cells themselves, usually.
Right. Although if the condition is really severe or has been going on for a very long time, they can sometimes become a little bit smaller and paler, microcytic and hyperchromic. But that's less typical.
Got it. Now, what's the really unique thing here? You said it's different from other anemias, like, say, from losing blood.
Yes, that's the first big takeaway. ACD isn't because of blood loss or, a primary problem making red blood cells. It's actually a systemic response. It's driven by inflammation.
Inflammation, okay.
So it's not a defect in the red cells. It's more like an interference with how the body normally handles iron,
Right.
and how it signals for red blood cell production, that process we call erythropoiesis.
So, expert, what's the really mind-blowing part, the counterintuitive twist you mentioned?
Okay, here it is. This is the really cool part. ACD is widely thought to be a protective response.
Protective. How is being anemic protective?
Well, the thinking is the body isn't just failing here. It's intentionally making iron less available. It's basically inducing this mild anemia on purpose.
Why would it do that?
To starve out potential invaders, especially bacteria, many bacteria need iron to grow and multiply, so the body hides the iron away. It's a defensive strategy, not necessarily a sign of failure. Imagine feeling sluggish because your body is fighting a hidden war.
Wow. Okay, that is different. So let's get into the weeds a bit. How does it work? What pulls the trigger for this defense?
It all kicks off when the immune system gets seriously activated and stays that way for a while. The main drivers are these chemical messengers, pro-inflammatory cytokines.
Cytokines, right. Like alarm bells.
Exactly. Think of them as the immune system's communication network shouting, "There's a problem." The key players we're talking about here are interleukin-6, or IL-6, tumor necrosis factor alpha, TNF-A, and interleukin-1, IL-1.
Okay, IL-6, TNF-alpha, IL-1. They sound the alarm. How do they mess with the iron system then? Because iron's vital for red blood cells.
Right. This is where a molecule called hepcidin comes in. It's basically the master regulator of iron in the body.
Hepcidin, the master regulator.
Yes. And that cytokine, IL-6, it tells the liver to produce more hepcidin. Think of hepcidin like a security guard for iron.
A security guard. How does that work?
Well, hepcidin's main job is to find and shut down something called ferroportin.
Ferroportin.
Yeah, ferroportin is the main doorway, actually, the only known doorway that lets iron out of cells. Specifically, the cells in the gut that absorb iron from food and these immune cells called macrophages that store iron like little warehouses.
Oh, okay.
So when hepcidin levels go up, It binds to ferroportin and basically tells it, shut down, lock the games. Iron can't get out.
So it's hitting it from two sides then. You can't absorb as much iron from the diet.
Correct. Impaired absorption from the gut.
And the iron already inside the body gets trapped in those macrophage storage units.
Exactly. It gets sequestered, locked away inside macrophages and also liver cells. So the iron is physically there in the body, but it's stuck. It's unavailable to be put into hemoglobin for new red blood cells.
Which leads to that functional iron deficiency you mentioned.
Precisely. Your blood tests will show low iron floating in the plasma, but if you could look inside those storage cells, the iron stores measured by ferritin are actually normal or sometimes even increased.
That's such a critical difference. It's not missing iron, it's inaccessible iron.
You got it. That's the core concept.
Does inflammation affect anything else in the iron transport system, like transferrin?
Yes, it can. Inflammation can also tell the body to make less transferrin. That's the protein that acts like a taxi, carrying iron around in the bloodstream.
Okay.
So less transferrin means a lower total iron binding capacity, or TIBC. And subsequently, the percentage of transferrin that's actually carrying iron to saturation also drops. It's all part of this strategy to keep iron locked down away from those potentially harmful bacteria that need it.
Wow, it's a really complex strategy. So the body is manipulating iron. But does the inflammation directly hit red blood cell production too?
It does, absolutely. Those same inflammatory messengers, particularly IL-1 and TNFi, have other effects too. They can directly tell the kidneys to produce less erythropoietin.
Erythropoietin,
Yeah,
EPO. That's the hormone that tells the bone marrow to make red blood cells, right?
that's the one. So the main signal to produce more red cells gets turned down.
Okay, less signal.
And not only that, these cytokines can also make the bone marrow itself less sensitive, less responsive to whatever EPO is around.
So even if the signal gets through, the factory isn't listening as well.
Kind of like that, yeah. And one more thing, these inflammatory conditions can also shorten the actual lifespan of the red blood cells already circulating. Plus, those activated macrophages we mentioned, they can become overeager and remove red blood cells from circulation a bit too early.
Man, it's hitting red blood cell numbers from all angles then. Reduced production signal, reduced factor response, shorter lifespan, and increased removal, all stemming from that inflammation.
Exactly. It's a multi-pronged effect.
Fascinating and quite sophisticated.
Mhm.
Okay, so knowing this complex mechanism, how do we actually spot ACD in an animal, like a horse? What are the signs we should look for?
Well, clinically, it's often pretty subtle. We call it subclinical sometimes. The signs are usually mild, kind of nonspecific, and they often get completely overshadowed by whatever the main underlying disease is.
So what might you see, if anything?
You might notice maybe a slight paleness in the gums or mucous membranes, some lethargy, maybe just general weakness. In horses used for performance, you might see they just don't have the same stamina, or exercise might cause their heart rate to shoot up more than usual, or they seem weaker during exertion.
But probably no obvious signs of, like, bleeding or anything.
Right. Usually you won't see signs of active bleeding, which is hemorrhage, or signs that red blood cells are being actively destroyed, which we call hemolysis. Any other major signs like a fever, weight loss, maybe a fast heart rate or breathing, or even a subtle heart murmur, those are typically linked back to the primary inflammatory problem, not the anemia itself.
So this inflammation, it's not just about fighting off a simple bug, is it? What kinds of underlying issues actually cause this level of chronic inflammation that triggers ACD?
Oh, it's a really broad range. ACD can pop up with almost any condition that involves long-term inflammation or even cancer.
Okay.
So for horses, think about things like chronic infections, maybe deep abscesses hidden inside the body, or chronic pneumonia, peritonitis, bone infections like osteomyelitis, even heart valve infections, endocarditis.
Wow, serious stuff. What about parasites?
Yeah, internal parasites are an interesting one. They can cause anemia directly through blood loss, obviously, but a long-standing heavy infestation also causes significant gut inflammation. And that inflammation can definitely contribute to ACD on top of the blood loss.
And you mentioned cancer.
Yes, neoplasia is a big one. Things like lymphoma, squamous cell carcinoma, melanoma. The cancer itself often creates a systemic inflammatory state.
So infections, parasites, cancer, what else?
Also, chronic inflammatory diseases that aren't infectious. like laminitis or that chronic respiratory condition, COPD or RAO, sometimes called HEAVES, even chronic tying up, which is exertional rhabdomyolysis, various granulomatous diseases, immune-mediated problems.
It's a long list.
It is. And even severe trauma or major surgery can cause enough prolonged tissue damage and inflammation to trigger ACD. As for who gets it, older animals might be slightly more prone just because they're more likely to have chronic issues, but really, our sources say there's no specific age, breed, or sex that's predisposed. It's all about the underlying inflammation.
So finding ACD really points towards needing to find that other problem.
Exactly. It's often a clue that something else significant is brewing.
Which sounds like diagnosing it could be, well, a bit tricky. It's subtle and linked to something else.
It absolutely is a diagnostic challenge. The way vets approach it is mainly as a diagnosis of exclusion.
Diagnosis of exclusion, meaning
Meaning you first rule out all the other likely causes of anemia. Is there evidence of bleeding? Is there evidence of hemolysis? Is there a primary bone marrow problem? You check for those first.
okay.
And then once those are ruled out, you look for evidence of that underlying inflammatory or neoplastic disease. If you find both the mild non-regenerative anemia A and D a source of chronic inflammation, it's about connecting those two dots.
So what would the blood work, the CBC, typically show?
Yeah.
You mentioned mild to moderate anemia.
Right. So the packed cell volume, the PCV, which measures the percentage of blood that's red cells, is usually down but not drastically. Typically in the 20-30% range for a horse. Normal is more like 30-45%. So it's low, but rarely super low, like below 20%. And the red blood cell count itself and the hemoglobin level will also be decreased. And as we said, usually the cells look normal, normocytic, normochromic, sometimes maybe slightly small and pale in really long-standing cases.
And the key feature, non-regenerative. The bone marrow isn't responding.
Exactly. And this is super important, especially in horses. You don't look for reticulocytes.
Right, you mentioned that. Reticulocytes are young red blood cells, and in dogs and cats, a high count means the marrow is regenerating. But not horses.
Correct. Horses just don't release significant numbers of reticulocytes into the blood, even when they are regenerating. So checking that number isn't helpful for diagnosing ACD, or really most anemias, in horses. Instead, you look for other clues on the CBC.
Like signs of the inflammation itself.
Precisely. You often see changes in the white blood cells, what we call an inflammatory leukogram, maybe high total white cells, high neutrophils, high monocytes. And then you look at other markers.
What kind of marker?
Things like fibrinogen, it's often elevated, maybe above 400 or 500 milli-GDL. And another one called serum amyloid A, or SAA. If those are high, they're strong indicators that there's ongoing chronic inflammation or antigenic stimulation. That supports the ACD picture.
Okay, so the CBC shows mild, non-regenerative anemia plus signs of inflammation. Now, you said the iron studies are the real key, the aha moment for diagnosis.
Yes, this is absolutely crucial for distinguishing ACD from true iron deficiency anemia, where the animal actually lacks iron.
So what do these iron tests show in ACD?
Okay, first, you measure the iron floating in the blood serum. In ACD, this is typically low, maybe in the range of 120 to 150 micrograms per deciliter.
Low serum iron. Okay, that sounds like deficiency.
Wait for it. Then you measure the total iron binding capacity, the TIBC. This reflects the amount of transferrin available to carry iron. In ACD, the TIBC is often normal or even decreased.
Normal or decreased TIBC?
So, low serum iron, normal to low TIBC. That means the transferrin saturation, the percentage of transferrin actually carrying iron, will also be decreased, usually around 20 to 52%.
Still sounds a bit like deficiency. Where's the twist?
Here it is. The final piece is measuring serum ferritin. Ferritin reflects the body's iron stores, the iron packed away primarily in those macrophages. And in ACD, ferritin is normal or, more often, increased.
There it is. So low iron circulating, but normal or high iron tucked away in storage.
Exactly. That combination, low serum iron despite normal or high ferritin, is the absolute hallmark of ACD. It tells you the body isn't lacking iron, it's actively hoarding it, locking it away because of the inflammation. That differentiates it clearly from true iron deficiency, where both serum iron and ferritin would be low.
That makes perfect sense now. Low available iron, plenty in the bank. That's ACD's signature.
You nailed it. Other tests, like looking at the bone marrow directly with an aspirate or biopsy, aren't usually needed. They would show decreased red cell production but increased iron stores, confirming the picture. But usually the blood tests, especially those iron studies, combined with finding the underlying inflammation, are enough.
Okay, this brings us to treatment. And this seems like where ACD really diverges from what people might expect. You hear anemia, you think give iron, but the sources strongly warn against that here, right?
Yes, this is probably the most critical, practical point. The treatment for ACD is almost entirely focused on finding and fixing the underlying chronic inflammatory or infectious disease.
So you don't treat the anemia directly at all.
Generally, no, because
Yeah.
the anemia is a symptom, a consequence, and actually a protective response driven by that underlying condition. So you need to treat the cause. That might mean long-term antibiotics for a deep infection, surgery to drain an abscess, anti-inflammatory drugs for something like RAO, managing chronic pain, dealing with cancer, or getting parasites under control with the right deworming.
You have to tackle the root problem.
Exactly. Trying to fix just the anemia without addressing the inflammation is like, I don't know, bailing water out of a boat without plugging the leak. It won't work, and you might even make things worse.
Okay, let's talk about why you don't just give iron. That seems so counterintuitive.
It does, but there are solid reasons. First, giving iron supplements by mouth probably won't even work very well because, remember, hepcidin is blocking iron absorption from the gut.
Right, the door is locked.
And giving iron by injection carries a risk of iron toxicity, which can be dangerous. But the biggest concern, the crucial warning, is this. The body is actively sequestering iron for a reason, likely to keep it from bacteria. If you force more iron into the system when it's already overloaded in storage, you risk overwhelming those storage sites, leading to iron overload in tissues, which is damaging. And perhaps worse, you might actually feed the bacteria that the body is trying to starve.
Whoa, so giving iron could potentially fuel the underlying infection.
It's a real concern. That's why iron supplementation is generally a bad idea in ACD, unless you have concrete proof that there's also a true concurrent iron deficiency happening, which is pretty uncommon.
Okay, that's a huge point. No iron unless proven otherwise. What about EPO? Giving that hormone to stimulate red cell production.
Also generally not done. Recombinant human EPO, the synthetic form, is expensive. But more importantly, horses have a significant risk of developing antibodies against the human form.
For antibodies, what would that do?
If the horse's immune system attacks the synthetic EPO, it can also cross-react and attack the horse's own natural EPO. This can lead to a much more severe treatment-resistant anemia called pure red cell aplasia. So the risk usually outweighs any potential benefit for the mild to moderate anemia seen in ACD.
Wow, okay, so no iron, no EPO. The focus is solely on the primary disease. What about supportive care?
Yeah, basic supportive care is always important. Good nutrition, making sure the horse is well hydrated, managing pain. But things like blood transfusions, very rarely needed for ACD alone. The anemia just usually isn't severe enough to warrant it.
So it really all comes back to fixing that underlying inflammation.
That's the take-home message for treatment, absolutely.
All right, let's talk about the outlook. What's the prognosis if a horse has ACD, and how do you follow up?
Well, the prognosis for the ACD itself is completely tied to the prognosis of whatever is causing the chronic inflammation.
Makes sense. If you fix the cause,
Then the ACD will usually fix itself. If you can successfully treat the infection, manage the inflammatory disease, or resolve the issue, then over time, as the inflammation dies down, hepcidin levels will drop, iron will become available again, EPO production and response will normalize, and the anemia will gradually resolve.
gradually. How long does that take?
It can take weeks, sometimes even a couple of months after the inflammation is truly under control. It's not an instant fix for the anemia.
But what if the underlying problem can't be fixed? Like, say, advanced cancer or chronic kidney failure?
Then, unfortunately, the anemia of chronic disease will likely persist, or it might even get progressively worse as the primary disease advances.
Are there major complications from the ACD itself? You said it's usually mild to moderate.
Right. Because it's typically not severe, major complications directly from the anemia are rare. Animals might be less tolerant of stress or heavy exercise, maybe showing that faster heart rate or breathing. But the ACD itself is very unlikely to be fatal. The danger lies in the underlying disease.
And when monitoring these cases, the focus stays on the primary issue.
Absolutely. You monitor the progress of treating the main disease. You might run periodic CBCs to check the PCV and red cell indices, looking for signs that the anemia is improving, but that improvement is really just a marker that your treatment for the underlying condition is working.
Okay, so wrapping this all up, this deep dive into anemia of chronic disease has shown us something pretty profound, hasn't it? It's this deliberate protective mechanism driven by inflammation, not a simple deficiency.
Exactly. It flips the script on how we might think about anemia sometimes.
So what this means for you, listening, Next time you or someone you know feels just vaguely unwell, that rundown feeling. Or you hear about an animal with a puzzling mild anemia. Maybe pause and consider. Could the body be in the middle of a quiet strategic battle, hiding resources like iron to fight something unseen?
Yeah, it gives you a real appreciation for the body's complexity and
Mm.
how sometimes things that seem like problems are actually, well, smart defenses.
It really does. This understanding of ACD deepens our respect for that often counterintuitive wisdom of the body's own protective systems. What part of this whole mechanism stands out most to you, that idea of protective anemia?
For me, it's definitely that deliberate iron sequestration. The idea that the body actively hides iron to fight infection is just remarkable. It really changes how you view the role of nutrients in disease.
Absolutely. So maybe a final thought to leave you with. How else might this concept apply? This idea of the body having responses that are protective but inconvenient. Where else in health, or even in other kinds of systems, do we see strategies that seem detrimental on the surface, but actually serve a deeper protective purpose?
That's a great question to ponder. It certainly makes you look at symptoms and responses in a whole new light.
It really does.
Yeah.
Something to think about.